Okay, guys, here's discussion C for you. We're discussing a report from the National Institute for Health and Care Excellence. NICE is the acronym. Okay. All right. So here we go. The article reports that the National Institute for Health and Care Excellence has decided not to approve two Alzheimer's drugs, donanemab uh, and lecanemab, lecanemab for use on the NHS, um, starting that stating that the clinical benefits are too modest to justify their high cost. Here's a quick breakdown. The drugs are antibody based therapies that target and clear amyloid buildup in the brain, which is associated with Alzheimer's disease. NICE's final draft uh, guidance found the treatments only delay disease progression by 4 to 6 months in early Alzheimer's, which it uh, it deems insufficient to warrant NHS funding. Okay. Okay. Manufacturers Eli Lilly, which make Donepraz, Donep, Nepra, Nep, Ab, and LS, which is the name for that, is Lecanab, plan to appeal the decision. Patient uh, patient charities are calling calling this calling the decision disappointing and a painful setback. These drugs represent a specific shift toward targeting unrelying causes rather than just symptoms. So, this development raises important questions about how cost effectiveness is defined in neurodegenerative diseases. Effectiveness um, is defined in neurodegenerative um, care. Want to explore the broader implications for dementia treatment or healthcare resources allocation? I'd be happy to dig deeper. The NICE decision sends shock waves far beyond the UK. Its ripple effects touch on how we define value value in dementia care and what what progress truly means in a field that has long grappled with. Hold on, I get paper. Slow in incremental advances. Here are some key implications. Reframing effectiveness. A 4 to 6 month delay in progression might be seen as modest clinically, but for patients and caregivers, that time can be deeply meaningful, especially in early Alzheimer's. This raises questions about how we weigh uh, st- statistical gains against against quality of life impacts. Barriers to innovation. The ruling could discourage pharmaceutical investments in disease modifying therapies if reimbursement systems won't support high risk uh, innovation with modest initial returns. That might affect the pace of drug development globally. Pressure on evidence standards. There may be growing demand for real world data and long term studies that better capture meaningful functional outcomes on just amyloid clearance or cognitive stress or scores. Broader shift toward prevention. If cost benefits uh, thresholds are harder to meet for late stage interventions, we may see a strategic pivot toward prevention and early detection, including biomarkers, testing, lifestyle interventions, and cognitive screening in midlife. Uh, Quality concerns. Restricted access to high cost treatments could deepen health discrepancies, especially if these drugs are approved in some countries, but not others, or in private systems, but not public areas or public ones. Okay, give me a minute, guys. This crossroads feels particularly significant as we shift from symptom management to disease modification. It challenges policymakers, clinicians, and advocates to ask, what is a meaningful gain in dementia care, and who gets to decide? Would you like to unpack this through the lens of U.S. healthcare policy or caregiver burden? There's a lot to explore. Absolutely. The NICE decision may be UK based, but it sends a clear signal to US policymakers, insurers, and advocates wrestling with similar dilemmas. Here's how it reverberates stateside. Reimbursement pressure. Medicare and private insurance are watching closely. If drugs like Doneb mem Doneb mab and less cannab offer only modest benefits at steep prices, coverage decisions could become more selective or require stricter evidence of real world effectiveness. Okay, Centers for Medicare and Medicaid Services, or CMS, has imposed limited coverage for anti-amyloid therapies pending outcomes from additional studies. Cost effectiveness frameworks gaining momentum. The U.S. has traditionally avoided the explicit rationing approach of NICE, but organizations like ICER, Institute for Clinical and Economic Review, are filling filling that role. We may see broader adoption of value-based pricing led tied to outcomes. Particularly for neurodegenerative conditions, where expectations are high and gains are in credential. All right. Equality and access tensions. High drug costs without broad insurance coverage create discrepancies whether patients may access these therapies through concierge medicine or private pay, while lower income populations wait. Rising ethical questions about who benefits from medical innovations. Caregiver costs considerations. Even a few months delay in cognitive decline can ease caregiver burden, which has economic ramifications. Yet this informal care value is hard to quantify in policy terms. The NICE decision highlights the disconnect between what is meaningful to families and what is reimbursable. Accelerated approval under scrutiny. The FDA accelerated approval pathway has brought Alzheimer's drugs to market faster, but without long-term effectiveness data. This approach is controversial. NICE's resistance may bolster arguments in the U.S. for more cautious rollouts. Okay, the cost, the care tension is between scientific moratorium and healthcare system. Pragmatism in the U.S. that plays out through Medicare policy, private insurance, negotiations, and public perception of fairness. If you're interested, we could zoom in on how caregiver advocacy might reshape the narrative around cost effectiveness or explore uh, parallels with past conversations like adultism. Where would you like to take it next? Several recent U.S. healthcare policies have been directly shaped by the rising costs of prescription drugs. Here are some of the most impactful. Okay, give me 1 second. Medicare Drug Price Negotiation Inflation Reduction Act. For the first time, Medicare is negotiating prices for high-cost drugs under the Inflation Reduction Act. The first 10 drugs selected used for conditions like diabetes, heart disease, and cancer will see discounts of 38% to 79%, saving Medicare estimated $6 billion in 2026 alone. Most Favored Nation, or MFN pricing policy. The Trump administration introduced a policy regarding drug prices. In the U.S. to match the lowest prices in comparable countries. This aims to end what officials call global freeloading, but it's controversial due to potential impacts on Medicaid rebates and the 340B drug discount program, which serve vulnerable populations. Okay, and then we're going to get into tariffs on imported drugs. A proposed 25% tariff on imported pharmaceuticals is intended to boost domestic manufacturing and reduce reliance on foreign supply chains. However, experts warn it could lead to higher prices and drug shortages, especially for generics sourced from India and China. Transparency and hospital pricing reforms. Reports show wild price of while price variation for the same drug across hospitals. Even within the same city, this has fueled calls for greater pricing transparency and reforms to standardize costs and reduce patient burden. These policies reflect a growing tension between cost containment, innovation, and equitable access. If you'd like, we can explore how these changes might affect caregivers, Medicaid beneficiaries, or the future of value-based pricing. Where should we go next? The implications of recent U.S. healthcare policies, especially those targeting drug pricing and insurance access, are wide ranging for patients. Here's how they're playing out on the ground. Lower out-of-pocket costs. Medicare's drug pricing negotiations under the Inflation Reduction Act are expected to significantly reduce costs for seniors, patients taking high-cost medications for chronic conditions like diabetes or cancer could see meaningful savings starting in 2026. Expanded insurance access. The expansion of ACA premium subsides through 2025 has helped keep insurance coverage rates high. Around 52% of Americans are now insured. This means more patients can access preventative care and chronic disease management without financial strain. Coverage instability for Medicaid enrollees. As states unwind pandemic eras, Medicare protects millions are undergoing eligibility reviews. Some patients, especially those with low income, gotta get paper. Literacy or unstable housing are losing coverage due to paperwork issues, not actual ineligibility. Transparency and empowerment. New rules requiring hospitals and insurance to disclosed pricing are giving patients more tools to compare costs while still impact impact. This shift could help patients make more informed decisions and avoid surprise bills. Okay. Equal gaps remain. Despite progress, discrepancies persist. High drug prices and patchy Medicare coverage still uh, disproportionately affect low-income and minority communities. Policies that don't uh, account for social discriminations of health may widen these gaps. All right, folks, keep an eye on what's going on in the healthcare world. See what you need to do to match these changes, because it matters to everyone who has to use Medicare, Medicaid, and get coverage for healthcare. So, I thought I'd do this show tonight for this. So I hope this gave somebody some information. For now, Gator Wellness, take care, folks. Hi, Pammy.